Just remember that we are looking at systematic reviews of prognosis. And last week we learned a little bit about prognosis itself. So those interested can go and see the video online and see what is the prognosis. So the newer classification of prognostic studies, for example, outcome of an individual with a disease. So patients with musculoskeletal disease, what is the outcome of musculoskeletal disease? Could be different. Or people with diabetes, what's the outcome of that? A prognostic factor. So in people with myeloma, what is the value of beta 2 microglobulin? One single factor. Modeling is usually a combination of prognostic factors where we predict an outcome in an individual with disease. So these are the three ways one can look at prognostic studies. Overall prognosis, one particular factor or a combination of factors which we call modeling. So what's the concept? This is just a joke. In the end, the lawyer will give the prognosis. Medicine is moving like that. The concept is like this. Let's say an outcome, always in math statistics, y is called the outcome variable, and x is called the predictor variable, or this is called the independent variable, and this is called the dependent variable. So, and then there will be some time. So, for example, Andrew looked at musculoskeletal diseases, and then they could have led to depression. Maybe in your model, you could put musculoskeletal, malignancies, diabetes, hypertension, ischemic heart disease. All are potential risk factors. And after some period of time, you look for the development of depression. So now this is the concept of a model. Yeah. So we are all used to this now. Now, I told you it could be a single factor. So sex as a prognostic factor for mortality in adults with acute pulmonary embolism. So follow up a group of people with pulmonary embolism and you see how many of them die. But you want to know, is there a difference between men and women? A single factor. Called a single factor. Identify a factor associated with outcome in patients with disease. It need not be sick patients. We just may be following up healthy people and see if there is a difference in gender, an outcome of depression or diabetes or something. And the factors are said to be independent. So the two factors, the factors which you are studying, could be independent of each other. The second example, we move to prognostic model studies. So prognostic model, remember I told you it's not just one factor, but many factors. So this example I'm going to use is from the study called the Prospect trial, looking at people with primary colorectal cancer. You're predicting who will develop metastasis. So already have colorectal cancer. Who is the person likely to get metastasis? So here model, remember, it's not just one factor, two or more risk factors molded into one model. That's what I showed you the picture earlier. You can do diagnostic prediction when I'm looking at it as a diagnostic utility of a test. That's not what we're talking about. Or prognostic prediction. That's what the value of our today's talk is. And after we make this prediction model, why are we doing this model? So a new individual will come after you develop the model. The new individual will now ask me, what is my risk of getting colorectal cancer? Based on the model which I learned from earlier, I'll tell him, this is your predicted risk. So we're trying to develop a model so that new people can benefit from that knowledge which you have gained. Now, the model performs, how do you know this model is doing well or not? So there are some words which we must learn. Calibration. So, if you remember sensitivity, specificity from diagnostic studies. So one can map sensitivity on the y-axis, 1 minus specificity on the x-axis, and you can draw a curve of how well your model does. This is also called ROC curve or receiver operating characteristic curve. It tells you how well your model differentiates people with disease from without disease. That is called discrimination. Discrimination. There's a second one called calibration, which I'll show you. Net reclassification index, net benefit, and finally decision curve analysis. These are little advanced and I can't take all these in today's class. I'm going to explain only calibration and discrimination. So for those of you who are interested, it's a very nice article in JAMA on calibration and discrimination. And this is the reference. So this is the ROC curve. sensitivity and specificity on this axis. A perfect test or a perfect model will be in orange. You go like that. And if you can imagine that this graph is a 1 into 1 centimeter area, the area under the perfect test, diagnostic test or a perfect predictor model will be 1 into 1 centimeter. Let us say this is the model. Let's say this area under the curve may be 80% or 0.8. A blue line is a useless line. It is not, test will not discriminate between disease and no disease. Might as well toss a coin. So this is called discrimination. Then calibration. Let us say that somebody has heart failure and I want to predict your 10-year mortality with heart failure. So I actually have actual data and I have the model. Here the model predicted data is what is predicting 0% chance of death in 10 years, 10% chance, 20% chance, and likewise. This is the actual mortality data which I had collected over the next 10 years. So what can you see here? The black line is actually what happened, and the orange line is what the model predicted. Let us take 40%. When the actual mortality was 40%, the model predicted slightly less than 40%. So the model underestimated mortality. This is different from discrimination, which is just yes or no. Can it differentiate heart failure, yes or no? Here, at different levels of probability, how good is the prediction? So both are two sides of a coin. One must look at calibration as well as discrimination. What I'm not covering is these points: net declassification index, net benefit, and decision curve analysis. These will do another day. So this is the cohort study I talked about, or the model. People with suspected colorectal cancer, and then you have a staging looking for metastasis, and therapy is given, and you collect the data and put it into a prognostic model studies. So it's like much like ANGLE study. So you give the anatomy of the cohort study, then only you can follow up the model. Now the model I told you is not just one predictor factor, but more than one predictor factor. Then I can have a model with only 2 factors. I can have a model with 3 factors. I can have a model with 4 factors. Who should decide? So instead of calling model 1, 2, 3, these people are calling it model A, B, C, D. So the standard known risk factors for colorectal cancer metastasis are called model A. When they added perfusion, local perfusion CT, they called it B. And as they did various other models, they have given what each model contains. So when you make a model, you must say these are the variables I'm using to predict the outcome in my model. You should label the models differently. That's the first thing. Next. Okay. Remember what I told you, model A, B, C, D. These are different variables in the model. That's all it is. Now, can you see here C statistic? C statistic is the area under the curve. Discrimination. And you can see calibration slope. Calibration slope of 1 means it's a perfect symmetry between predicted and actual. That's the calibration slope. And then there's another one, new words, AIC and BIC. This is called Akaike information criteria, and this is called BIC, or Bayesian information criteria. The lower the AIC and BIC, the better the model. So can you see among all these models, which is the lowest AIC, BIC? So the first one, model A. So the model A is actually, they said, is the best model. It's got a reasonable discrimination, reasonable calibration. It's also got low AIC and BIC. So this is how one can look at, you develop a model and you say among all the models which are developed, this is the best model, right? Okay. Now, let us say that one of you wants to develop a model for one of your studies. Let us take 13 steps to a model. And this is an article by Georgia Salanti and colleagues. And it's published in BMJ 2023. Now, somebody will say like, oh, this is a bit too much, 13 steps. What happens if you don't follow the steps correctly? You land up in trouble. So why is this baby crying? Because the baby came down without climbing down the steps. So we should not ever skip any steps. That's the message of the joke. Second message is slow and steady wins the race. So sometimes these are not things which one decides, I'll do it, complete the project in a month's time. Takes time. So what are the 13 steps? First, what is your aim? What are you trying to predict? Develop a team. Don't say I, me, and myself. You have to have a team of people who are making a model. Review literature. Only then you know what are the predictor factors which are already known. And write a protocol. This is what I am planning to do. Second step. If there's already an existing model, maybe we can just update that model instead of creating a new one. There's no good model, then you're forced to create a new model. Step 3. What is your outcome measure? That incidence of diabetes. What's the outcome measure? Then, what are the predictor factors? And if the predictor factor is diabetes, how should it have been measured? Is it fasting glucose? After eating glucose? Is it HbA1c? How do you measure that risk factor? Then you have to collect the data and look at the quality of the data that you have collected. Garbage in, garbage out. Then consider sample size. Again, Andrew study, they mentioned sample size was collected. That was done, but did not mention. So there's a simple rule of thumb. For every 10 outcomes which are good or bad, so for every one outcome which is good or bad, you need 10 subjects. So that's the general rule when you're doing a model. Next step is deal with missing data. So I didn't know in Andrew's cohort study, did they talk about how much missing data? So generally cohort studies will also have missing data, also called attrition. Next step, fit the model, like the model I've shown you. Then the performance. Fit the model means you make a model equation. Y is equal to X plus blah, blah, blah. That's the equation. Then you try calibration, discrimination, and reclassification, decision curve analysis. And then you finally decide, okay, model A is very good. Like the previous example, I said model A is very good. Then you do decision curve analysis. Finally, assess the predictive and individual predictor. So now I said this model A has got 6 variables. Among the 6, which is the best one? You can try that, but you don't, the model is meant to be many variables together. Lastly, write it up and publish it. So many people try all these things and they say, nothing worked out. But you must, the labor must be shown to the world. So just to summarize that, model development, you take data from which are predictors, individual predictors, then you make an internal validation. In the first set of data, you try to validate the model, where you collected the data. If the model is working well, you try external validation. External validation is you try the model on a new group of people in time and space. And if the model has external validation, then you put the model in real life. See what happens. How well is the model doing versus just clinicians who don't have the model? And is there any outcome benefit of having used the model? Let us say the model is developing outcome predictors in emergency for sepsis. And then everybody uses the model. Another group of people don't use the model. What happens to the two groups of patients? The outcomes become better. Economically, it was better. So there may be so many outcomes one could measure. That is the impact of the model. Now, I told you about a single model. From a single model, now we are going to move to systematic review of models. What is that? There is one model. Let us say in Andrew's study, there was a single model for depression prediction. Now, there are 5 such cohort studies of models. So, today's class is about combining all 5 models together for 6 models in a single systematic review. That's why I had to take a long time on explaining what is a model. So then I can go a bit faster on systematic review of model. So we're just combining many models together. So this is the article by Debray and colleagues, and it's published again in 2017, Systematic Review of Prediction Model. So the first step is to make a PICO question. I mean, I know it's like elementary again. Elementary, my dear Watson, it's all in the PICO. PICO will go to that. Once you make a question, then you must search for literature. Remember, we're doing a systematic review. We're not doing a primary cohort study. or prognostic study. We're collecting other people's prognostic study. So you have a question and study design, then you search. First, you make a search strategy, then you actually search, then you screen out articles which are not good, in those to include, those to exclude. Then you do a critical appraisal or risk of bias. Then you extract data, meta-analysis, heterogeneity you check for, grade analysis, interpretation, and finally use the Prisma checklist and tripod checklist for publication. That's the steps that I'm briefly going to take you through. These are the steps of systematic review. It is a little more complicated. Systematic review of prognostic. Let's go to PICO. P is the population. So, for example, Andrew studies Danish population who happened to go to the GPs there. What's the intervention? That's the intervention is the model. What are the risk factors together which you're going to call model? That's the model. You may have to, you may want to compare two models, or sometimes you say only this particular model I'm looking for. I'm not comparing it. Outcome of interest, you will define clearly what is the outcome of interest. Now, timing. Two timings are important. For example, when is the prognostic factor measured? So, for example, in Andrew's study, he said, if the person had hypertension in the washout period, then that timing is bad for the study, so that patient won't be included. So, the timing of when the predictor factor or risk factor was collected is important. It works very nicely with your study. Second is, when is the outcome measured? And what, you can't just say the outcome is depression. At what particular time point after entry into the cohort will the outcome point be measured? So timing is very important. And the setting. For example, Andrew's study was done in a Dutch. So that prognostic model in a Dutch country may not be applicable to rural South India. So when you're doing a systematic review to say what kind of setting that you're wanting your studies to have been in. So this is the P4TS of the CHARMS checklist. It's called the CHARMS checklist. So just remember there are types of questions. A specific patient group. So for example, recurrent stroke after TIA. Or quality of life after ARDS. So ARDS is the group. TIA or transient ischemic attack is the group. So specific patient group. Or you may say that I'm in nephrology, going to be in nephrology, and I want to know all models in nephrology, how do they do? Or it may be more specific. I want to know cardiovascular mortality in India. I want to predict cardiovascular mortality in India. So this is an example. Cardiovascular risk prediction in India, they have recalibrated the Framingham model. So somebody has taken the Framingham model and said, let me improve upon an existing model. So because I think that the Framingham model may not work so well in India, developed in a Western country, let's do that. So that is a specific model in a specific population. The last one is the added value of a factor to a model. So for example, let we know that TB meningitis, what scoring system do we do? 2-8 score. Is there a newer scoring system? The Lancet score. So now you all know this ROC curve. This is the ROC curve for TB. We're not great, but that's a 2-8 score. 2-8 score doesn't have imaging, right? So now this is the ROC score for the 2-8 score alone. And this is the ROC score for the Lancet score, because now we have added imaging and other factors. So now you can see, like, compared to this has slightly improved. So that is the added value of a factor to a model. So this is another way a model can be done. Next we come to searching. So obviously there are some tips on how to search for prognostic models. One tip is given by this article. I'm not going to go into it, by Dear Singh and colleagues. The second article, which is given here, unfortunately it's in here, is by Ingui and colleagues. And the third one is by Elena Stallings and colleagues. So there are no particular guides how to find it, but clearly you have to be able to search literature where to find these prognostic models. So that search part of it, those articles are there for anybody who's interested. Next, we come to data extraction. Now we are screening the articles and we have to extract data. So one needs a checklist to know what data to extract from each modeling study. There are 6 studies that say how to extract the data from those studies. There's a checklist for that, which is called the CHARMS checklist. Okay. So the CHARMS checklist looks at something. First, are we doing diagnosis or prediction? What is the scope of the review? Type of modeling study, is it a single factor? Is it a model? Who is the target population? What's the outcome? What's the time span of prediction? And the intended moment of using the model. When should the model be used? So these are the, whenever we do a systematic review, what we have a data extraction form. For each study, this is the data I will extract. So I'm just going to tell you obviously the source of data. Was it a registry like Andrew study? Was it a case controlled cohort? Who are the participants? The P of, so we know for you what age group, which gender, which city was the previous study. What are the outcomes to be studied? So the outcome, type of outcome, whether the outcome was blinded diagnosis for a registry trial, the doctor saw the patient and made a diagnosis of depression. But he never knew at that time that we are going to do a follow-up of, see, 10 years ago, did this patient have hypertension? In that sense, a registry-based diagnosis is blinded because the person making the diagnosis did not know that later on somebody will come and follow up and see whether. So you don't know whether the outcome was blinded or not and what the timing was. Remember, the timing is very important. Then the candidate risk factors. These are the predictor factors. You combine many index factors and they become a single model. So what are those candidate predictor factors? Sample size. So each model should mention the sample size. How many patients they followed up to make the model. Missing data. And how did they handle missing data? It's increasingly important because they follow up 10,000 patients for 10 years. You may miss 2,000 patients. Did you exclude those 2,000 patients or did you include some data and say, this is what the data would have been? Important to know. Then how did you develop the model? So we'll not go into that situation of this model development, but one needs to take data to how one developed the model. Then the model performance. I told you calibration, discrimination, sensitivity, specificity, and the model evaluation. Did I develop the model in one data and did I evaluate on a separate data? Or did I take one data set and divide it into two? Last week we have taken that. So there are different methods of model evaluation. So that's what the question is being asked. Finally, what were the results of each individual study or each individual model? And how did they discuss? What did they say? What are the strengths and limitations? Did they say it's very useful or more research are required? So these are the kind of checklists that one needs to have when one extracts data from a modeling study. Now we have extracted data, we also need to do this thing called critical appraisal or risk of bias assessment. Each person calls it differently. So risk of bias. Now the Cochrane Prognosis group gives a large number of references. I just put up this reference so that people later on can check out these references. Now, remember, suppose I'm just doing this risk of bias assessment for a single for prognostic factor, not a model, a single factor, let's say gender. Then it's called the QUIPS checklist, QUIPS. And this is a reference for the QUIPS checklist for risk of bias. So what are the QUIPS risk of bias? So from, let's say, Andrew study of Dutch people who are being followed up for depression. Selection bias is, did you really get a random sampling of all Dutch people? Well, in that study, every single Dutch person has to go to the Dutch health system. It's not that poor people went to health system, richer people went to private GPs. I'm assuming that such thing. That's called selection bias. The selection of your cohort may not have been very good. The second bias is attrition bias. Now, again, we don't know from the previous study what was the loss to follow up. Did all those millions of Dutch people follow up only in the health system? Maybe 20% immigrated to some other country. Or some other people decided to go to alternate streams of medicine. I'm just saying. So attrition bias needs to be looked at. The next bias is prognostic factor measurement. Let's say the person says, I have hypertension. And just before blood pressure was measured, it's your final year exam. And you had 3 cups of coffee. Your bladder is full. Now you're diagnosed to have high BP. I'm just giving all the risk factors for a wrong measurement of blood pressure. Or instead of measuring blood pressure 3 times, one took a single first measurement. It's called measurement error. So when you measure the risk factors, was there any bias related to the prognostic factor? So there are many possible biases possible in the prognostic factor. Similarly, outcome measure. Was the outcome measure done properly in that particular study? How was the outcome measure collected? Was it measured correctly? That's bias in that. Confounding. Now, for example, I say that alcohol causes heart disease, ischemic heart disease. We know that most people who drink alcohol actually smoke. It's the smoking which causes heart disease, it's not so much the alcohol. So if I didn't measure that smoking, then I'll conclude in my model that alcohol is a strong risk factor for ischemic heart disease. So in the model development, if they consider confounding. Okay. And lastly, how was the statistical analysis done? Was it done and reported properly? Remember that there's a statement, I forgot in the author, if you torture the data long enough, it will speak p values to you. I'm making my own joke about it. So what are we chasing? Some significant p value. And if you keep on doing analysis, you will finally find a significant p value. That, by the way, is not anybody's statement, it's just a silly joke. Okay. Now there's a modeling. So instead of risk of bias for a single factor, which is QUIPS, what about risk of bias for a model, meaning many risk factors together? That is called the Probast checklist. Probast. Prediction model of risk of bias assessment tool. Robust. And if some people are using artificial intelligence to develop prognostic models. So there's an extension of the Probast tool called Probast AI. So we're not going to go into that Probast and Probast AI. I'm just showing you that there are tools available for that. So now we're going to go into the meat of today's talk, which is a critical appraisal. I've told you about what is prognosis, prognostic factor, prognostic modeling, how the steps of a systematic review are done. I'm going to show you a systematic review and go through the checklist, much like what Andrew did. How are we doing for time? So maybe we'll do another half an hour and then we'll stop. Okay. So this is the checklist. For those of you interested in picking up the Cochrane prognosis methods checklist for prognostic factor modeling. So I've just taken this and I've given the reference down here for people who are interested. And this is the article which I shared yesterday, not yesterday, last Saturday, which was after TIA, what's the risk for getting a stroke? And the story I told you is a true story. My uncle had a TIA and we were wondering what's the risk of having a stroke in the future. That's the model which I'm chasing to see. Has someone done a single cohort study? Oh, somebody did a modeling and somebody did a systematic review of modeling. That's even better than looking at a single cohort study. That's the story. This is the article published in JAMA, which is Providence. It's almost the same time when my uncle was admitted. So this is a checklist which I'm going through. And when you see this, it's from the checklist. The first one is who are the authors? So the authors were Faizan Khan and some colleagues from Calgary in Canada. What type of review was it? It was overall prognosis of people with transient ischemic attack. And the name of the reviewer, that's me. So I'm reviewing this article. And it's not just Faizan Khan alone. It's a group of authors called the Persist collaborators. And it's a large group of people who have done this prognostic model. Potential conflict of interest of me, peer reviewer. I'm the peer reviewer. I'm peer reviewing somebody else's. For example, in Andrew's study, Andrew might have some conflict of interest and wanting to show that hypertension causes depression. Very unlikely. But when you're doing a critical appraisal, you need to also step up and say, I have a conflict of interest or I don't. I may have a conflict of interest to promote a drug, in which case I may say the study was very good, even when the study was actually not so good. So are there any potential conflicts of interest? No, I don't have any. Any of your organization or entity. So maybe in the past, I worked for a aspirin company, a clopidogrel company, and I want to promote the use of these in TIA. So the conflict of interest may be related to my organization. or any relationship in the last 36 months. I may have taken money for lectures. So even if it's not related to this, I have to say that yes, GlaxoSmithKline gave me like money for some other lecture, or I may be the author of one of these papers, then I have a conflict of interest because how will I do the critical appraisal of my own paper? I'll obviously find no flaws in it, right? And declare any potential conflict of interest even if you're not sure. So it's always wiser, especially I'm teaching all when you're submitting any article to a journal, declare any potential conflict of interest. So you have to declare your conflict of interest before proceeding. So I have none. Overall impression. Was the review easy to read? Sometimes you read an article and you like at the end of it, you don't know whether it's hieroglyphics written by some old Egyptian. Was the use of language well structured? Was the review easy to understand? Were their key messages clear? Yes. Recently, we looked at infographics, critical appraisal. Nowadays, people don't want to even read the abstract. They want to look at a picture. So, can you make a single picture of the whole review? People can easily understand. Is the question clinically relevant now to somebody in cardiology, or let's say somebody in anatomy or physiology? No. But as a physician who's managing TIA patients, yes, this question is relevant. So it's only relevant to the like beauty is the eye of the beholder. Every question is relevant to somebody. But for me today, this question is relevant. No other comments. Title, abstract, and plain language summary. The title and abstract should be a good reflection of the full review. Does the title reflect the objectives? Is the abstract understandable? Is it less than 1,000 words? And does the abstract represent the full text? Sometimes the abstract will be spun. You know, cricket. What Nishi? Junior Nishi. You like cricket? No. Senior Nishi. Spin or fast bowling? Useless fellow. There's spin bowling. What is spin in real life, Akash? When you say English spin, other than cricket, what is spin? Put a spin on the story. What do you think is other than cricket, non-cricket? He spun the story well. Making it up, the study found no significant difference between two groups, but the abstract was written in such a way that people will think that there might have been a difference. In fact, there was probably a difference. And it's called spin. So many people write abstracts because they know that most people won't go through the whole article. They will just read the abstract, and the abstract is written in such beautiful way that it will convince you to do whatever it is. So we will be careful that abstract is not spinning a story. The abstract should be free of links to you should not have references, additional tables or figures in an abstract. So let's have a look at the abstract. This is how JAMA importance, objective, data, study selection, data extraction, main outcomes, results, and conclusion. It looks fairly well structured. And they have a separate section called key points. Now, in Cochrane, they say that even these key points may not be understandable to a layperson. Let us say my relative is a non-doctor. What is going to happen? The risk of hazard ratio before the hazard ratio. So they say there should be something called a plain language summary. Somebody at 10th grade education should be able to understand what is written there. So was the title appropriate? Yes. Was the abstract reflective of the Cochrane of the review? It's not a Cochrane review, but answer is yes. Was there a plain language summary? Unfortunately, it didn't have a plain language summary, but it just had one paragraph on what is new. So very often people now just put one sentence. What is already known, what is new. But a good review should have something written in plain English so that common man can benefit from this systematic review. Okay, the clinical questions, scope and background. Was the objective and type clearly specified? Was it an overall prognosis, prognostic factor, or a model? What was the health condition? What is the clinical context? What's the setting? Was the factor clearly described? What was the health outcome and what was the time horizon? Time horizon means when was the outcome measured? They look at heterogeneity. Heterogeneity means Why one study can find something, another study will find something different? What is the scope and rationale? Was it a broad question, like a prognostic factor, or is it a focused question? One single factor, sex, predicting the outcome in patients with disease A. And is it an important question for policy makers and healthcare providers? Or is it some topic which is very esoteric, very few people in the world will actually be interested in this systematic review? So I found the review was focused because I said we looked at TIA outcomes after 90 days. Most people have looked at short-term outcomes after transient ischemic attack. It was an overall prognostic model. The time horizon was clear. They have mentioned 4 points why there may be heterogeneity. I'm not going to go through all four, but for example, somebody may do passive surveillance. A registry-based study is called passive surveillance. If you come to a hospital with a stroke, you're registered. It's not that, oh, you have TIA, every month I'm going to follow you up. Phoning you up every month is called active surveillance. So there may be a difference between one study did passive surveillance, another study did active surveillance. So like this, they have identified 4 factors which are possible for heterogeneity. And I think it is important to me, but it may not be interesting for somebody else. Based on these principles, is the clinical question of the review appropriate, clearly described? And I said the answer to that question is yes. Based on this principle, is the scope of the review, not the question, now the whole review, appropriate and clearly described. And I thought, yes, the scope of the review is appropriate. Based on these principles, is the background section of the review complete and clearly described? So very important when you write an article, even though the background section, you're given usually maybe 1 or 2 paragraphs. In an MD/MS dissertation, that occupies 50 pages. Because we have a lot of space given there. But in a journal article, 2 paragraphs has all you have to justify why you're doing a systematic review. So you have to comment about that. I thought it was yes. Criteria for including studies for this review. Selection criteria. So I'm not going to go into this, but this is where not the P of the individual prognosis study, but for study, what type of cohort study will be included? Picking up? Correct? No. Just see if it's clear. If the online audience can tell us if it's not clear, that will be better. Apologies if the sound was not clear. Let's leave it down. Should go. Can't you get to the All right. So for the online audience, small apologies if it wasn't clear. So basically, what type of studies you're going to select is an important point. Again, I want to stress the timing of the prognostic model or factor and the timing of the outcome. So when you are doing a cohort study, when did you measure the risk factor? When did you measure the outcome is an important point. Did you pilot test the inclusion criteria? Suppose you say, I want only elderly people with TIA, you may not do any studies. Then you may be forced to change your inclusion criteria and say, I'll take TIA anybody above the age of 50. So you must pilot test your inclusion criteria. Did you take prospective or retrospective cohorts? Here, this study has taken prospective and retrospective cohorts. What was the definition of TIA for this particular systematic review? Whatever the article said was TIA, they have taken as a definition of
TIA. But they also mentioned it could be time based, meaning the neurological disease should last less than 24 hours, or tissue based where there's symptoms less than 24 hours and no new infarct on imaging. So they're not doing a study, they're taking other people's study. So how do you define the risk factor of TIA? They've said these two definitions. And they also added minor ischemic stroke if your NIH SS score was up to 5. Now, suppose one person does a cohort study, you may publish it in multiple journals 1 year follow up, 5 year follow up, 10-year follow up. You should not add all three and say, I got three studies together. So, you must take the one with the longest duration. Because the 10-year follow up will include data from the 5-year follow up and the 1 year follow up. So, this is something you have to use systematically. One same study published in 3 places should not become 3 studies. Then you're double counting the same patient. So, were the inclusion exclusion criteria clearly described? Yes. Were the reasons for excluding studies clearly described? Yes. So, that one comment is there no mention of excluding studies. The next one is literature search. So, now we've done this so far. Literature search. They searched Medline, Embase, or any topic specific databases. So, have they given an electronic search strategy? Many I searched, we all know how to search PubMed. What word did you use? Prognosis, model, PIA, outcome, death. And they should give you those words because other people will not believe whether how you search was correct, inappropriate or not. And the dates reported. I searched up to 2020. Hey, we published a study in 2025, but we searched literature only up to 2020. Maybe there were other prognosis studies from 2020 to 2025 might have been used. So the dates of the search are also important. Let's have a look at this. Any language restriction. I will not include Chinese, French, German. There can't be only cohort studies done in English language countries. There may be others. So we should not have any language restrictions. So then there was a collaboration with the research librarian, Medline, Embase, and Web of Science. They searched up to June 26, 2024. The article was published in 2025. So generally, if you within 6 months of your publication, you should have done a repeat search. They could have actually done a repeat search just before this, but it's not bad. They've done it up to June 26, 2024. The key words were TIA, stroke, study design, and prognostic research. They have done reference list searching. Suppose you get one prognostic study. You get one prognostic study that may give a reference to another prognostic study. So for the faculty doing systematic review ones, if you find one good article, use that article to search for other articles. For PGs, with your thesis, suppose you get one good study. That one good study may give references to other studies. That's called reference list searching. And I'm going to show you the appendix. They use this Covidence software, which they are also using in medicine to MCU, for data extraction. It's an online data extraction software, quite easy to do. It's paid, so I'm not trying to promote it, but it's one of the simple online software where the article will pop up. You can easily extract data and put it into the software, and it aggregates everything very easily. So, for example, I'll show you one. They searched Medline. They also searched Embase and Septa Medica database. So, there are many databases. Much like Andrew showed you that you have a Venn diagram. The same article may be in PubMed and in Embase. So, to make sure that overlapping articles are taken off or duplicate articles. Right. And they also search Web of Science. Now, I'm just showing you one thing. For example, the word transient ischemic attack could come as TIA or transient or ischemic attack transient. So you combine these two words, stroke or ischemic, you combine these two words. And finally, you combine all of them to look for TIA. Then you say animal, only human studies, and you limit to infants to all. So you slowly build up a search strategy. So though we just simply put one word in PubMed, there's a science behind how you search literature. and they clearly described how they searched the articles. Then, incidence or prevalence, risk factors, prognosis. So they have clearly described their search strategy very well. So they found out 23,000 articles in 3 databases. And they found 3 additional through searching some of these articles. 13,000 abstracts were screened. 143 full text articles were got. That is, nearly 13,000 articles were irrelevant. Only 143 were looked at in full text. Finally, they said 65 were potentially eligible. Finally, they couldn't get data from 27 studies, and they had only 38 studies included in the meta-analysis. That's also a large number. 38 cohort studies of EIA, which had prognosis model in them. They're given a list of studies excluded from the meta-analysis. I mentioned earlier that they didn't talk about excluded studies. That's wrong. They actually did give a table of studies. Why did they exclude this nice study? Let me give a reason. So, for example, these 4 studies, Hornick, Caroline, Ferro, Evans, unable to contact the author. So the data which was there in the paper was insufficient for me. I can't take out any data from this paper. You email the author, but the author doesn't respond. Well, you can't include because there's no data to include. They could have looked for specific neurological databases. For example, there's a database called StrokeNet. All stroke studies are in there. Another one called SITS, it's a Global Stroke Registry, where all stroke studies are published. And the search terms seem to be good, extensively given in the appendix. Dates of the search were given, and additional searches they found 3. Now I found one more database. This is an article, 1-year risk of stroke after TIA, and they have given a website here called TIA.org. So there's a TIA registry.org. So they could have also searched this particular registry called TIA registry.org. So you may get some of the TIA studies which are not available. We could have tried some of them. Okay. Based on all these questions, what do you think about the search strategy, good or bad? Good. Were they adequate or appropriate for the literature search? Yes. Were any important studies missed? No. I was not aware of any studies which we have missed. How do you extract data? Remember, I told you the CHARMS checklist. We did the CHARMS checklist for data extraction earlier. So did they use a CHARMS checklist? Did they look at population, prognostic factor, outcome, follow-up, study design, moment of prognostication, meaning when was a prognostic factor measured? Or 2 independent people extracting data. So for the PTs and faculty, if you're doing a systematic review, you have a paper, 2 people separately must independently extract the data. And if you disagree, a 3rd person must adjudicate. So were they having standardized forms which are pilot tested for all important data extracted? Suppose you have 4 or 5 groups of people extracting data, they all do the same thing. And if you didn't have data, did they contact the authors of included studies? So here they have did data extraction. 2 reviewers independently extracted the data. And they have contacted the authors for missing data. They've given all the data, what all data they have extracted from each paper. They've also mentioned that they've classified as active surveillance and passive surveillance. The ICD classification of disease was used for passive outcome ascertainment. So they have given large details. And remember, this important study looked at people after 90 days. They were really interested in after 10 years after the TIA, how much risk of stroke you'll have. That was the important data they were trying to get from the authors. Okay, and they mentioned that if authors did not communicate, we're mentioning that. So this is the same thing. Studies excluded from meta-analysis, a large list, and they must give the reason for exclusion. So if anybody is doing a systematic review, why you included the study, why you excluded the particular study. And then characteristics and estimates of the stroke risk in the excluded studies. Maybe the studies which you excluded had a higher risk of stroke or a lower risk of stroke. So reader will be confused. Hey, maybe you did some underhand technique. The studies which didn't say what you wanted, you conveniently excluded. So you have to give some data about the studies which you excluded as well. Next, characteristics of studies which you did include. So the country, for example, Netherlands, was it a prospective, retrospective, hospital based or community based? When was the study recruited? What is the population? How many were male, age? What is the definition of TIA? Time based or tissue based? What is the follow up? Percentage of people on antithrombotic? Was the outcome of stroke active or passive? So all this data was collected from every single of the 37, 38 studies which they included. And they have given a summary of the 38 studies. How many were from Europe? From Asia, there were 7 studies. So suddenly my uncle asked, hey, you did a better systematic review. Were there any Asian studies which reflect us, or only studies which were from Western countries? But there were Asian studies as well. They were mostly hospital based, but 21% were population based. Some were before 2007, many were after 2007, and the age, gender, and the way the diagnosis was made. So, these are the general baseline characteristics of the overall study. And remember, I am really interested in 10-year follow-up. What percentage for 1-year follow-up, 5-year follow-up, and 10-year follow-up? Most of them had active surveillance. And the risk of bias will come to, they determined that the overall risk of bias was low in 95% of the studies. So people say it's garbage in, garbage out, but these people say, no. It's good studies and the results are going to be good. So the charm checklist, as I mentioned earlier, participants, outcome, predictor factors, sample size, missing data, how was the model developed, model performance, evaluation, results and discussion. We've already gone through that. And there's another guide for systematic review. How to go about doing a systematic review of prognosis. And this is published in 2019 by Richard Riley, Doug Altman, and Thomas Debray and colleagues. So this is a guide how to do that. So there's a CHARMS PF checklist, which is used for prognostic factors, and there's a CHARMS checklist for prognostic models. So the same kind of a checklist is meant to be used. So based on these factors, was the process of extracting data appropriate? And were no important items missed? No. They didn't use a CHARMS checklist. Now, of course, the authors will say, who is this CHARMS checklist? I can have my own empirical fund. But generally, they use the principles in CHARMS checklist, but they didn't use the word, we use the CHARMS checklist. So, we're doing a Cochrane review, I have to say yes or no. But we should not say that they didn't use my name checklist, that's bad. But they didn't use the CHARMS checklist. Were the data appropriately summarized in the text and characteristics of included studies? Yes. So these are the characteristics of included studies, and I'm just showing you the table again. Risk of bias assessment. They have used a QUIPS tool for assessment of risk of bias in prognostic factor studies. PROBAS tool is recommended for prognostic, but they didn't use QUIPS, I'm just saying. QUIPS tool is for a single factor. PROBAS tool is for model. Overall prognostic studies is an adaptation of QUIPS tool. So were the elements of the risk of bias clearly defined? Was risk of bias done by 2 independent assessors? So imagine every Saturday, the same article done by one of our postgraduates. 2 of the postgraduates do the same presentation. And we should compare and see whether, hey, you said randomization was good, you said it's poor. That's the only way to make sure that somebody is doing a good job. Two people independently do that. And if you pilot test the tool, meaning one or two articles are done by everybody, and then we come to an agreement. Then only we know, okay, we all agree when you say randomization was good, it was done well. Not for this, we don't do randomization in this. The authors of study, did they contact the authors of the original paper if they couldn't have enough information? And was it done separately for each domain? Did they incorporate the quality of the studies into the final assessment? If the study showed that this is a 10-year list, but the studies were poor quality, therefore we take the results of the pinch of salt. Have they married the strength of the evidence with the quality of the evidence in the final study? How was it used? In the inclusion studies, stratified analysis means poor high risk of bias studies. If you include them, what will happen? What will happen if you exclude them? Sensitivity analysis means we never planned this, but after the study was over, we found a couple of studies with high risk of bias, so we decided to exclude them. We are showing you the risk of bias, I mean the results with and without them included. Meta regression is a sort of a statistical technique and you adjust for that bias. So what did they do? Two people looked at risk of bias independently. They used a score which is called Newcastle-Ottawa scale. Not exactly the scale which they said, but this scale was developed in Canada. There's a Newcastle-Ottawa scale for post-case control and for cohort studies. And I'll show you the Newcastle-Ottawa scale. That's not bad. So they used the Newcastle-Ottawa scale. There are 3 selection criteria of patients and 3 outcome criteria. And it looks at the representativeness of the study cohorts, ascertainment methods, unbiased outcome measures, and the adequacy of follow-up duration and completeness. And they have given a scoring system where if the score was 4 or more, then they were low risk of bias. Generally, people don't like scoring system for risk of bias, but this Newcastle-Ottawa scale gives a score. If you score more than 4, the cohort study is well done. So this is the Newcastle-Ottawa scale which they've used. Selection criteria 4, comparability 1, which they're not looking at here, and outcome criteria 3. And they have given a table, risk of bias assessment in this systematic review. This is the author's name. How well was the patient selection, ascertainment of TIA, demonstration that the patient didn't have stroke at the onset, outcome assessment, 3 criteria, and the final score out of 6. So most studies scored 6. They said anybody more than 4 is good. So you can see one particular study here. Sorry, Jacob 2019. They assessed some criteria having high risk of bias. They gave a score of 2. So overall, they said 36 of the 38 studies had no risk of bias. So overall, we can say that the studies had good quality or low risk of bias. So what is your assessment of risk of bias? It's good. They didn't use a quick score. They gave a score. But still, I think the risk of bias is appropriate. So they looked at all the points, but they didn't just use the scores or the quips which was recommended. Based on the results of the risk of bias, have they described the risk of bias in the text? Have they said that based on this, our results should be looked at like this or like that? Now I am going to data analysis. What is a narrative summary? So narrative summary is, at the end of the study, you find that one study was done in children, one study was done in adults, one study was done in geriatric population. So then we may say, oh, the study was done in different populations, so I shouldn't do a mathematical summary of that. One can always combine 1 plus 2 plus 3 and give average, but it may not make sense to add 1 plus 2 plus 3. So a group of doctors or people must sit together and say, yeah, they've got data from 7 studies. But does it make sense to combine them? If it doesn't, we can just simply give the results of the 6 studies and say, these are the 6 study results. That will be called a systematic review with narrative summary. You take the 6 studies and you mathematically combine them together. That's a systematic review with meta-analysis. So you must not always say that we are forced to do meta-analysis. No, you're not forced to. If it doesn't make sense as a doctor, don't do that. Can we compare the various risk factors? Is there significant heterogeneity? If there is significant heterogeneity, then you must ask, did it make sense to combine the studies? One study is showing protection, one is showing no difference, one is showing significant harm. Then how can you combine that? A thin man and fat man is not average weight man. That's wrong to combine them together. It doesn't make any sense. What type of meta-analysis? Random effect or fixed effects? Random effects assumes that every study is telling its own rule. But we are just mathematically combining them together. Fixed effects means there's only one single truth, and whatever studies don't find, we get one meta-analysis result. Whatever the individual studies are getting away from that final result is an error. So there's only one truth which the study systematic review find out, and we penalize all studies for being away from that final summary. That's called a fixed effects model. And they do subgroups a priori, meaning we look at before 2007, after 2007, tissue-based diagnosis versus tissue and radiological diagnosis. That was planned. Unplanned means, oh, let us know there's so much data, let us make multiple subgroups. A priori is always better. Grade approach, I think Andrew is starting heavily in today's presentation. Andrew gave a lovely talk on grade. But this is grade for prognostic studies, not grade for systematic review studies, RCTs. There's a different grading of approach that we can look at. So how did they do data synthesis? They used a random effects model and they used a Simeon-Leard method. We don't have to go into that. And they used for heterogeneity the chi-square test and the I-square test. Previous time I looked at chi-square, I-square, and we interpreted heterogeneity. Subgroup analysis, they looked at location, North America, South America, Asia, prospective or registry based or retrospective subgroups, population based or hospital based. Was it TIA alone or minor stroke or both together, active or passive? These are all planned before. They planned to do subgroup and studies done before 2007. Why do we do time based? Because care changes. Over time, what is experimental may soon become standard of care. Over time, we must also divide with systematic reviews. And they looked at studies which looked at 1 year, 6 to up to 5 years, and 5 and up to 10 years. So they looked at also those kind of outcomes. So based on these factors, were the methods for analyzing the data clearly described? And I thought the answer, the methods were clearly described. Was there a rationale for pooling or not pooling? Yes. Were the subgroups and sensitivity analysis in accordance with the protocol? Yes. Was grade assessment done? No. Unfortunately, they didn't do any grade assessment. So this is the last week we did grade for RCVs. There is a grade article for prognostic studies. So they could have done a grade assessment, but they didn't do the grade assessment. So this is the protocol, long-term risk of stroke after a TIA or minor stroke. It's published in the Prospero Systematic Review database. And this is the more details of the same protocol and the plan synthesis. So very important when you're reading somebody else's systematic review. What did they plan to do? What did they actually do? That's why when we bring RCT critical appraisal, we always go back to the protocol. What did they plan to do? What did they do? Were the results published and what all they wanted to do or not? So we must also go back to the systematic review protocol. Results. Do the included studies match the inclusion criteria? Yes. Do the results follow the data? Yes. Were all planned models addressed? Yes. Were the results reported in an appropriate format? Yes. So let's look at the results. I told you they're going to do subgroups. Subgroups. This is all the whole results. Any stroke. 1 year, 2 to 5 years, 6 to 10 years, and the cumulative incidence of stroke in 10 years was 19.8%. That means anybody with a TIA in 10 years' time, 1 in 5 of them will have a stroke. And then last week we looked at 5 years is about 12.8, and 1 year is about 9.8, roughly. They're giving you subgroups for ischemic stroke, hemorrhagic stroke, fatal stroke, disability, myocardial infarction, and all-cause mortality. We are really interested in the components of the outcomes are given here. And this is the figure which I showed last time, cumulative incidence and time. And 10 years, the risk of stroke is up almost 20%. And this is the incidence rate. So much like Andrew's previous study, after an incident, depression risk is highest immediately, then it goes down. So similarly, after a TIA, the incidence of stroke is highest in the first 2 years, and then it goes down, and again after 10 years, it slowly seems to go up. These are the major results of the study. I'm giving you the subgroups of the same thing. I remember I told you location. Asia, the rate ratio for compared to Europe, we have a higher risk of stroke. Registry based, administrative database of prospective cohort or registry, no difference. Recruitment before, compared to the recruitment before 2007, there seems to be a difference. Passive ascertainment, compared to passive ascertainment, active ascertainment seems to have a higher risk. This is planned subgroups and data being shown. Okay, so these are the planned subgroups. Risk of any stroke in 1 year. These are all the 38 studies, and this is all the data for each study. And in the bottom is given this combined results. This is the combined risk for all 38 studies together, 0.06, and the confidence interval is also given there. Importantly, I square, you remember, is 97%. What does that mean? Significant heterogeneity. I square 0 is no heterogeneity. 100 means it's all over the place. 0 to 25 or 30 is reasonable. 30 to 60 is moderate. More than 60 is significant heterogeneity. So those results are giving very nice summary. If you summarize 38 studies, we get a study with very narrow confidence interval. That doesn't make it a great result. Significant heterogeneity. So somebody may question, when you found significant heterogeneity, were you justified in doing a meta-analysis? Maybe you should have just given the results of the 38 studies separately as a narrative synthesis. Now, next one. Incidence rate of any stroke. Sorry, this one is 1 year. This is 2 to 5 years. In 2 to 5 years, again, there was significant heterogeneity, 89%, and you get the incidence rate here. What about 6 to 10 years? Again, there's significant heterogeneity. But the results are giving here, the incidence rate is given. They've used the random effects analysis. Okay. Case fatality. Similarly, for case fatality, also you can see here, some studies had a case fatality of 0.1, some of them 0.5, some of them have 0. So the heterogeneity is significant, 85%. Just to show you how to get used to understanding the systematic review results. But this is the final result, 0.1, confidence interval 0.07 to 0.14. One will think, yes, the results are highly believable. Then if somebody looks at this, we say, oh, there's a small problem. Let's take these results with a pinch of salt. The discussion, conclusion, and summary findings table. Was there an appropriate summary of the results? Were there any concerns about interpretation? Concerns about interpretation means the results showed something, but you spun it and tried to say something else. In the discussion section of an article or of a dissertation, again people try to put spin. If you put spin on the results, what should call it? Instead of 0.1, you make it 0.2. But stealing, falsification. That is a criminal offense. So in some countries, if you find falsification, you will be debarred from the college, that institution, and your degree will go. That's a serious offense because people may change practice. But if you put spin, I meant to say this, but you are understanding like that. So that's why people often in the discussion section abstract they use a lot of spin. So be very careful. Critical appraisal, be careful about the context. Have they discussed the clinical and policy context? Have they come look at all the evidence? So suppose you find that a new drug doesn't reduce mortality, but only some obscure outcome is different. On the publication, there is no mortality data, only that obscure outcome is there, and the whole article is spun. The drug is very good for this condition, in small brackets for this outcome, which is not relevant. So people often do these kind of hidden tricks. Next, we must compare with other published evidence. So I'm going to mention Bradford Hill criteria. One of the criteria is other people also have found the same evidence, then you are more confident, right? What are the implications of practice? Implications of practice is, yes, let us start doing dual antiplatelet for all TIA. Implication for research is, hey, the studies are all poor quality, let's do more studies. Or if you say there are enough good quality studies, please stop doing large cohort studies of TIA. It's a waste of time. Do something else. Summary of findings table, we'll talk about that. Lastly, can you understand the whole summary? Let's look at the discussion. They have said 1 in 5 stroke patients may have risk for stroke in 10 years. The increase nothing. 10% of all subsequent stroke are likely to be fatal. Yes, that's the point one they got. Annual risk of stroke decreases by 5.9% in the first year, by an average of 1.8% per year thereafter. That is what is from the data. The cumulative risk of stroke rises over time. A 2% risk in 1 year, two times the first year risk at 5 years, and 3 times the first year risk at 10 years. That seems like a reasonable thing from what they said. 50% of subsequent stroke risk occurred after first year. Why did they highlight this? Most TIA patients are followed up only for 1 year. After 1 year, they said, don't worry, you won't have any stroke. But they found in this study, after 1 year also, there's a 50% of the stroke may happen in the next second year to 10 years. So the risk of subsequent stroke is high. This is not readily apparent in routine clinical practice because we may follow up a patient after 1 year. Somebody else may see the patient in the second year. Very unusual for the same doctor to see a patient for 10 years. That was the doctor seeing after many years may not realize the question of TIA earlier. But now it's important for them to know, hey, we had a TIA in the past. Policy suggestions, secondary prevention. We generally stop dual antiplatelets after 90 days. Now they are questioning that. Long-term transition from primary care to a primary care. So let's say that after a TIA, the neurologist see for 90 days. When the neurologist sends the patient back to the GP or the PHC doctor, that message must go to the GP that, hey, this person had a TIA, but don't forget to follow him up subsequently. Okay. So they have given some importance of vigilance, of monitoring. What are the strengths of the study? Unpublished aggregate level data. We're doing a systematic review. We're getting data from authors published and unpublished data. We're putting it together. Overall, it said low risk of bias. They were able to tell you the natural progression of TIA, which many people do not know about this overall picture. They standardized the duration of follow-up across different cohorts. They're giving you exact person time risk. And instead of doing a single large study, they got the benefit of doing imaginary huge number of people together. And you can give a precise estimate. And it's from a diverse group, 20 countries, 4 continents. So they are saying generalizability is good. Pre-specified subgroups, yes, I showed you the pre-specified subgroups. And we're not going to just before 2007, after 2007, and they have given you a reason. It's interesting. Why is the risk of stroke more after 2007? Because CAD became better, all of us smarter than our ancestors. Because now MRI came. But what happens if MRI came? Many stroke mimics are excluded. Let's say hypoglycemic patient came with some weakness or TIA. If the sugar is controlled, he has a very good outcome. But if you do a good workup, including MRI and Vellore, you are truly left with only TIA patients who have much worse outcome than stroke mimics. That's why after 2007, the outcome appears to be worse. But they got an explanation for why that has happened. Active surveillance also after 2007. Passive surveillance might have missed many strokes after 2007. So these are some of the explanations. And they've also given something about why is Asian countries higher TIA risk, ethnicity, cultural differences may be there to explain. Lessons learned. The focus, patients with TIA, lower risk of subsequent stroke than people with TIA or a minor stroke. The long-term risk is based on the baseline risk. MRI changes the whole story. Long-term prognosis is sometimes still not well understood. So we should look at traditional risk factors as well as non-traditional risk factors in the future. Why, if you do everything well, people still have a risk of stroke. There may be other risk factors which we didn't consider. Okay, so I'm not going to go through the other limitations, but just to understand that they have given a large chapter of verse on limitations of their study. Okay, this is the final conclusion. Patients who had a TIA or minor stroke have a persistently high risk of subsequent stroke. That seems to be a reasonable conclusion. There's no spin in that. Right. Based on these factors, does the discussion and conclusion provide a comprehensive overview of the study? Yes. Was a summary of findings table completed and included? Sadly, they didn't have a summary of findings table. So I'm just going to show you. This is an article published in March 2024 in Cochrane. Diabetes as a risk factor for tuberculosis. In other words, I have diabetes today. I'm following up to see whether you got tuberculosis. The single factor prognostic study. What's a single factor? It's not prognosis of a group of human beings. Diabetics, the risk for developing tuberculosis. So there's a systematic review of various cohort studies, not only one. And here they have got a summary of findings table. So the topic is diabetes, a risk factor for TB. P is general population. The setting is outpatient or community. Risk factor is diabetes. Comparison is no diabetes. And you can look at the overall 10-year risk of all that. This is the outcome is TB. Less than 10 years, more than 10 years, the follow-up. Let's look at less than 10 years follow-up. The hazard ratio for getting TB is 1.52 and the confidence interval. More than 10 years, if you follow up, that's hazard ratio of 2.44. This is the annual risk of TB in people with diabetes, 102 more per 1 lakh population compared to non-diabetics. And if you follow up people more than 10 years, this is the extra risk given here. This is called summary of findings table. Can you see the quality of the evidence somewhere? Great. See, our study didn't include the grading of evidence. But you see here, hey, this is very good, but the problem is low quality evidence. So the policymaker will say, should we give all diabetic patients INH prophylaxis? 102 is not bad. Somebody will say 102. 102 patients in TB in the lakh population, high. But the quality of the evidence is low. But then look at for more than 10, less than 10 years follow-up, there's still moderate quality evidence. Oh, moderate quality evidence, maybe I'll change my policy. The summary of findings for table is very important for administrators, policy makers, even clinicians. You must make a summary of findings table, marrying the strength of the evidence with the quality of the evidence. Now, I'm just giving two references. If you want to do grade assessment for single factor or for prognostic models, these are the two references which are available. And for this particular thing, they'll tell you they use the QUIPS tool for doing the grade of assessment. And you have to say that why did you put low grade evidence? Huh? I don't agree. We took a lot of trouble getting high quality studies. Finally, downgraded the evidence. Let's just look at one. It says here A. You can see here A. Downgraded due to risk of bias. Most of the studies had moderate risk of bias across all the domains of quiz. So to give a reason why you are saying that the evidence is not good quality. Overall assessment. The review is acceptable in the correct form. The review is acceptable with minor revisions. I put substantial revisions. Why? What do you think? Oh, too tough. Great. Well, other than say a great study, everybody was not a lifelong dual attribution. They didn't do a great assessment. Maybe the quality of the study different from risk of bias is great. They've taken risk of bias as great. It's not. They didn't do a great assessment. The last sentence. If you submit to PLOSMET is an open access journal. The reviewer of the journal, let's say that you submit an article to a journal, and let us say that Deva is the reviewer. Just give comments. Based on our comments, the editor will decide whether your article should be published or not. The reviewer's comments will also appear in the journal. So then it can be with your name or just put anonymous reviewer one. So you have to say that I agree to be acknowledged in the published review. So you have to be agree, otherwise you should not be a reviewer. For other journals, the reviewer's name is never shown. So you have to say, yes, I agree for my name to be shown in this. I agree to be acknowledged on the website. If you agree to be acknowledged, your name, your email address, your phone number, so that you'll understand form. But nowadays it's not the same. Everybody has your all details will be available on the net. Do you have any affiliations? We are from this hospital, my affiliations. So that's the last part of today's talk. It was an exhaustive talk, but it's a bit of a different topic. So what did we do? First looked at what is cohort study, and the outcome of a long-term is prognosis studies. It married beautifully to Andrew's long-term cohort based on what is it called? Record for registry-based trials. So you follow up many people. That's simply a cohort study. When you want to predict what predicts the outcome, then you say a single factor or many factors together is called a model. A single study is called a single cohort study or single model. If you combine many prognostic models together, this is called systematic review. Today we have gone through the critical appraisal of a systematic review. Sorry, it's been a long session, but it's new kind of information. I want you all to learn this because most studies are observational, most studies are RCTs. Most studies are observational. So we should not chuck off observational data and say it's not good. We should do systematic reviews of observational data. Any questions?